Hi again, everybody. Welcome back to our series on planning for an endometriosis surgery. This is part three, and we are going to be discussing further about various areas of endometriosis. To start off, let's start off with bowel endometriosis. Bowel endometriosis is very challenging. Bowel endometriosis could be single, multicentric, or multifocal. It could be in the pelvis or even extrapelvic in the rest of the abdomen. It is usually associated with other deep endolesions most of the times, and many times is associated with a frozen pelvis where access to the pouch of Douglas is obliterated because of the bowel endo. There are three major types of bowel endo surgery. We could have the shaving, normally done for the rectal involvement, the discoid excision, sometimes also a double discoid excision, and we also have resection and anastomosis. How is this decided? Well, it's decided based on the size, on the depth of involvement, on the circumference of involvement of the lumen, on whether there is stenosis or not of the lumen, and the number of lesions. We start off with rectal shaving, which is, I would say, the least invasive surgery of the three. Now, keep in mind that bowel endo usually is a posterior compartment disease, and this is usually done when the depth of invasion is mostly superficial and sometimes up to the submuscularis. But I would say that again, the approach would be starting pararectally, cranially going downwards, approaching from the sides to where it is adherent towards the posterior uterus and the torus, but don't attack directly the disease. Be very cautious with energy devices, and if you have to use them, use those with minimal collateral damage, thermal. You would then shave off the anterior rectal wall, making sure not to go beyond the muscularis. But if it sometimes does go and you have to occasionally maybe go deep and you see there's a thinning of the area, you can take a couple of stitches over the area. After the shaving, if possible, obviously do a rectal air insufflation test and a methylene blue dye test to see if there are any thinned up areas of the bowel. And if there are, then ensure that you take stitches over these to strengthen the area. If blue staining is noted, consider interrupted sutures over the serosa in this area. The next procedure would be a discoid excision. This is usually done when not very wide or not very long, and usually in single lesions. You would free the rectum from all around by dissecting in the pararectal spaces and in the rectovaginal space, and free the bowel. Free below the nodule by at least 2 centimeters or so. Prepare the area by preliminary shaving first to thin up the area so that you don't have a big nodule that you have to take in between the stapler. Put stay sutures above and below the nodule to be excised. So you'd put a stay suture above and below, and then when you tie it, you would actually have this pushed down. So you have two options after this. You could actually excise and repair with sutures, or you could now use transanal staplers. When you're talking of transanal staplers, we have the option of using a semicircular stapler, which is when you have a large discoid and shaved area between almost up to around 8 to 10 centimeters. And you could use a circular transanal stapler for smaller discoids up to around 3 centimeters in the upper rectum and up to the rectosigmoid area. In some areas, you would do one discoid and then follow it up with a second discoid as well. So you have a double disc removal. You have to be careful about especially making sure that in a circular stapler that you don't take the posterior wall of the rectum by mistake. So you'll have to orientate it in such a way that only the anterior wall, so you have put your hand down, and the anterior wall is taken as you push the sutures in with the lesion going in that you can then staple together. We now go to bowel resection and anastomosis. When would this be done? In multiple lesions, in a sigmoid lesion or nodule, when it's a very long lesion, or when it's a very wide lesion covering more than 30% of the circumference, or when it's a lesion that actually is causing compression and stenosis of the lesion, of the lumen of the bowel. How would we be doing this? You would actually free the bowel again from above downwards, pararectally, and mobilize it well all around. We would stay close to the wall of the serosa of the bowel as much as possible in the transmesenteric plane. You would free the bowel all around, including the retrorectal space, and from the mesorectum and the mesocolon as well, but try to preserve these. Be careful about thermal injury to the bowel wall, and try shaving off all or as much fat as possible off the bowel wall in that area. Once this is done, you would dissect through the rectovaginal septum as well below, mobilize the rectum for at least around 2 centimeters below the distal end of the nodule, and you would keep in mind a proximal dissection line close to just above the lesion. So you don't need to take a very far dissection line below and above the lesion. This is a benign disease, and if you resect it just enough to cover the lesion, that should be usually enough, unlike in actual bowel surgery or colorectal surgery where there is malignancy suspected. So the area that you need to cover does not really have to be microscopically free of disease. Once you have done this, you section the distal site first using a linear stapler. After you've done this, you can actually do a stapler cut and consider mini-lap for the proximal resection, or you can sometimes do a direct cut and consider a transrectal nose procedure, that is a natural orifice procedure. So after you've done this, you would then take the proximal resection above the nodule, which could be done with a mini lap, pull out the segment and resect proximal, following which you would insert the anvil into the stump of this colon and fix it with a stitch around it. Alternatively, you can actually have it stapled and put the anvil coming out on the side. So it becomes end to side. Once you've done this, return the stump back into the abdomen, close the mini lap. Proceeding from here would be now the circular transanal procedure, which can be either an end-to-end or end-to-side anastomosis. And do not forget to check for bleeding around the staple line and check for safety test using air insufflation and methylene blue at times. So very important to ensure that that is correct. Caution, make sure it's tension-free, avoid devascularization of the segment, avoid the staple line overlap. So when you're doing it, that's why I try not to have two staple lines mix. You get it out on the anterior or posterior of the staple line, but not directly on the staple line. And be especially careful around the angles of the staple lines where you could take additional single sutures to ensure the staple line security. Be also very careful when you have two separate staple lines or suture lines together. So if you have done a bowel resection and a dorsal vaginal fornix resection, be extremely careful. You've done a TLH and a bowel resection. You have a bladder nodule with a TLH. You have a bladder with TLH and rectal resection. Now that's three staple lines. Be extremely careful. There is a high risk of fistula, and you may sometimes need to consider leaving an omental flap in between. The safety tests include the air insufflation test through the rectum, rectal methylene blue test, and you could also use ICG, indigocarmine dye, indigocarmine green dye, for vascularity testing. So, what are the controversies around bowel surgery for endo? Do we need a diverting stoma or not? Ideally not. These are young women who usually heal very well, and this is not usually a malignant lesion, so the healing process is quicker as well. Is there a need for a drain or not? That's a personal choice. Many times it's not necessary, but whenever in doubt, it's safer to leave a drain than to have a problem and not be sure about it in a few days. There is a controversy and there is a caution about a low rectal resection, that is 5 to 8 centimeters from the rectum, from the anal verge. There's a high risk of anastomotic leak. There's a high risk of a neurogenic rectum or bladder risk, and there's a high risk of Lars syndrome, which is the low anterior rectal resection syndrome. So in bowel endo, it's always important to ensure that you inspect the whole bowel, including the appendix, small bowel, cecum, etc. Let's move on to the next form of endometriosis, which is diaphragmatic and thoracic endo. These are women who would usually complain of catamenial right shoulder tip pain. And whenever you hear that they have pain in the right shoulder or having a pain in the chest region during periods, it's almost guaranteed that they have some form of thoracic endometriosis or diaphragmatic endometriosis. The right is more commonly involved than the left. You can also get catamenial pneumothorax or hemothorax, catamenial coughing blood, hemoptysis, and there is also catamenial lung collapse seen in some women whenever they leak and the bleb actually leaks into the abdomen. It can cause a lung collapse, into the chest. So we start with diaphragmatic endo. We would make a diagnosis by symptoms because they'll complain of shoulder tip pains or chest pains whenever they have this lesion. We could do an MRI chest, or we could examine it during a laparoscopy for the endometriosis or any other reason, and you would actually inspect the diaphragm. But keeping in mind that only the ventral part can be seen in laparoscopy in a dorsal lithotomy position. To understand more, you may need a left lateral decubitus or head-up position to visualize the diaphragm below or beyond the liver. And sometimes you may actually have to release the falciform ligament to view the dorsal diaphragm. You may also need to lift up the liver onto one side to see the area that is beyond or below and overlying the kidney, the fascia over the kidney. Otherwise, you'll miss these lesions. You could see them as lesions on the diaphragm, which are like nodules, or you could actually see them as fenestrations, especially in the central tendinous part. These are the ones that lead to pneumothorax or serous or bloody pleural effusions, and sometimes even partial herniation of liver into the chest. So those small fenestration lesions are usually a problem because they are also very difficult to repair in that area. The approaches could be obviously the the trans-abdominal laparoscopic approach, or we could have the VATS approach, visual assisted thoracic surgery approach. The only problem with VATS is you will only see lesions from the upper end if these lesions are full thickness lesions. Otherwise, you may not see these lesions from the thoracic side, because many of them start from the abdomen side and they may not have gone all the way through to the thoracic side. What is the approach to these lesions? Number one, it should be pre-planned, not an intra-op decision to do diaphragmatic surgery. It should be pre-planned. You should have a cardiothoracic surgeon on standby as a compulsion. Whether to approach it by VATS or laparoscopic or combined or a mini thoracotomy is to be decided later. Thoracoscopic, remember, can only see full thickness lesions, and many lesions will not be seen from the thoracic side. If you get catamenial pneumothorax, most of the times it is suggestive of thoracic or pulmonary disease, and a VATS approach would be preferred. If you are having lesions very close to the phrenic nerve, a mini thoracotomy may be needed to protect the phrenic nerve. If you have large diaphragmatic defects, you may need to excise and stitch. But if it's a very large defect, you may need to excise and plicate or put a mesh. If you have superficial lesions, you may end up, or you may get away with just coagulation or ablating using low energy source mechanisms. Blind pleurodesis is not recommended because you're not releasing or removing the disease. You're just trying to make the pleural space obliterated, which actually creates more pain because the lesions are there, and now it will make your subsequent surgical approach almost close to impossible. So be extremely careful. But if you excise the lesions and then follow it up with pleurodesis, that could be acceptable so that you don't have a risk of pneumothorax or the like later, or pleural effusion later. That is acceptable, but only as long as the lesions have been excised. What are the risks of this type of surgery? Be very careful with the left side. There is pericardium there. The diaphragm is usually a very thin muscle, so you have to be cautious about that. Be ready for possible pneumothorax management. So have an intrapleural drain ready. Make sure that your anesthetist is prepared for this kind of surgery, and if possible, they have a 2-lumen, ET tube would be helpful. There is risk of post-op pneumothorax, for which you may need to leave a drain in for some time. Damage to the phrenic nerve is a risk, so you have to be extremely careful on the medial aspect of the diaphragm. Post-op hemothorax is a risk, and recurrence, especially after pleurodesis, if you've done pleurodesis, then it's extremely difficult to now handle subsequently. So these are the problems with diaphragmatic endo. Tips about surgical approach to diaphragmatic endo. A double lumen intubation is preferred over a single lumen. It avoids the risk of pneumonia as well. Alternatively, you could use intra-op deflation after a single lumen intubation to allow the procedure on one side and not the other side. Post-op chest drain can be left in situ for a few days, 2 to 6 days sometimes. And if you are very close to the phrenic nerve, consider minothoracotomy. Polyglactin mesh can be used for a large defect. Post-op GnRH analogs, or is there a role for bilateral salpingo-oophorectomy, especially if fertility is not a concern, is something to discuss because you don't want a recurrence in the thoracic and the diaphragmatic area over and over. You don't have too many approaches to that area. You cannot repeatedly do surgeries in that area. So is there a role for BSO? Is there a role for long-term use of GnRH analogs? Maybe with some add-back therapy to prevent the side effects of the bone with the GnRH analogs. We go into now the abdominal wall endometriosis, which we have scar endometriosis, umbilical endometriosis, and maybe inguinal region endometriosis. So the treatment in most of these areas is obviously wide excision. And sometimes if the defect is very large in the anterior abdominal wall, it's wide excision with a mesh repair. And you may need a multidisciplinary team approach for inguinal endometriosis in view of the very close proximity to nerves and vessels. What are the risks? Risks about incomplete excision, risks of cosmetic issues, risks of mesh side effects in such patients, risks of nerve injury in the inguinal endometriosis area. So these are things to be kept in mind when doing abdominal wall endo. But if you have a lesion, please excise the whole lesion. Otherwise, you're not going to give this patient any relief from symptoms, and it's going to obviously recur or residual disease will remain. We touch up on frozen pelvis. This is the ultimate challenge in DIE surgery with a very high risk of complications. Following the principles and anatomical guidelines is mandatory for this kind of situation. What are the principles to a frozen pelvis? Remember, normal to abnormal, don't attack the disease first. Known to unknown, areas you know better to areas that you don't know because of the anatomical distortion. Easy to difficult, start from where the steps that are easy and then go towards the difficult so that they slowly become easy as you move on. Go millimeter by millimeter. Don't be in a hurry. Don't take big bites. Take small bites. Retroperitoneal approach is almost mandatory because that's the area that will probably be untouched and might be able to give you space to approach. Follow the planes. So follow the principles of dissection to go into the avascular planes. And if you follow the planes and do sharp and not blunt dissection, then you'll have minimal blood loss as well, and you'll not have risks of unnecessary adhesion formation later. You should know the correct use of electrosurgery, keeping in mind short bursts, low setting, pinpoint buzzing whenever needed. So this is correct use of electrosurgery. And you can use any electrosurgical or energy device that you're comfortable with. You could use the bipolar shears, you could use bipolar incisors, you could use the monopolar, you could actually use the ultrasonic energy. You have to keep in mind tissue traction when dissecting so that you can go into the right planes. Make sure you get sufficient exposure as you proceed. So if you have to do ovariopexy and suspend the ovaries and suspend the uterus and suspend the bowel to get your exposure, so be it. But it's very important that you actually end up getting a good exposure. Good hemostasis is important as well before you proceed. So these are principles to approaching a frozen pelvis. What about hysterectomy for DIE? So does hysterectomy solve endometriosis? No, unless that endometriosis and all the associated nodules and lesions with this endometriosis are also removed during that hysterectomy. If not, the hysterectomy will not solve your problem. You could get the uterus out, leave the lesions, and the patient is going to come back continuously complaining of pain even after the hysterectomy. So what are the rules about hysterectomy for deep infiltrative endo? It's a difficult procedure. It's not a straightforward hysterectomy like the others. It's not a routine TLH. And hysterectomy may not cure all symptoms unless all the lesions are equally also removed. And it will only be effective if total with complete excision of all lesions. So subtotal hysterectomy has no role in endometriosis because it is definitely going to cause persistence of symptoms. Ligation of the uterine artery at the origin can help in severely distorted anatomy, especially with control of hemorrhage. And if you have to do it with oophorectomy, sometimes in some patients it may be necessary, then please explain higher risks of coronary artery disease, CCF, obesity, high blood pressure, etc., associated with a premature menopause, but giving them information that hormone replacement therapy could still be an option for such patients after removal of the disease. Because leaving the ovaries there, yes, does slightly increase the risk of recurrence of disease in such women. One, rules about hysterectomy for DIE. Laparoscopic approach is anytime better than an open approach. So an abdominal hysterectomy is not a recommended approach in endometriosis. Follow all the principles of DIE surgery for this type of TLH. You need to have a complete, thorough retroperitoneal knowledge of anatomy for this type of TLH. And always, and without fail, do safety tests at the end of every procedure involving hysterectomy in DIE. Caution when you open multiple lumens and have many suture lines, for example, bladder, vagina, with the bowel, etc. Please be extremely cautious. Thank you very much. That brings us to the end of preparing for a deep infiltrative endometriosis surgery, part 3. So this was how to approach endometriosis surgery from my perspective. Thank you very much and have a good evening, everybody. Bye-bye.